And we're going to talk about global and regional left ventricular systolic function today. I'm going to try to speak into the microphone, but everyone in the room can also hear me, right? Okay, perfect. Okay. I have no disclosures. Alrighty. So the left ventricular muscle fibers, they're arranged in a helical configuration. So with every contraction, you're going to have multiple changes in different directions, different spatial directions, where your myocardium is going to shorten in a longitudinal, circumferential, and radial direction. And then the base and the apex rotate in opposite directions, similar to wringing of a towel. And so the goal of each contraction is to generate a stroke volume. And with left ventricular systolic function, it can be evaluated by echo by a lot of different ways. And we'll try to cover most of them today. Fractional shortening is one of the earliest ways to evaluate systolic function. It measures the degree of how much your LV cavity gets smaller with every contraction, and it technically gives us like a ballpark of your ejection fraction. So you can use this if the heart is either symmetrically good or symmetrically bad. So, no significant isolated regional wall motion abnormalities. And you calculate it as an end diastolic diameter, subtract end systolic diameter, and then you divide by an end diastolic diameter. And you can look at fractional shortening of the LV cavity in either the peristernal long axis or the peristernal short axis at the mid-papillary level. And normal values for 2D measurements is at least 18% or above. And then for M-mode measurements is at least 25% and above. And these values should correspond to an ejection fraction of about 50 to 55%. And any fractional shortening value of 14% or less is severely abnormal, and that's going to correspond to an ejection fraction of less than 30%. But remember, this has limited clinical use because you're measuring the myocardial function in just one plane, and you're describing the contractility by only looking at two walls. So similarly, the concept of fractional area of change, again, you're taking a left ventricular end diastolic area minus an end systolic area, and you're dividing by an end diastolic area. And again, limited clinical use because you're only looking at contractility in one plane at one level, usually at the mid-papillary level. So it's not going to be accurate in patients with wall motion abnormalities. And then just briefly touching on the point of E-point septal separation. Another way to roughly estimate LV systolic function. So an M-mode is done at the level of the anterior mitral leaflet tip and the interventricular septum. The first larger peak, which is your E-point, corresponds to the maximal mitral valve opening and early diastole. Second point is your A point and corresponds to the atrial contraction and later diastole. And the distance between the E point and the interventricular septum in diastole is measured. Anything less than 7 millimeters normal, anything greater than 10 millimeters abnormal, and suggests that your systolic function is pretty reduced. Guidelines recommend volumetric measurements to calculate ejection fraction, and this can be done by using a modified Simpson's biplane. It essentially, you're making geometric assumptions. So you're assuming that your LV cavity long axis is perpendicular to your short axis cross sections, and the LV cavity is traced at the blood pool interface. So that means it's along the border between your compacted and non-compacted myocardium. And you're tracing it in the apical 4 and apical 2 chambers. And the computer software then divides the LV cavity into multiple discs, where each disc has a calculated volume. And then the summation, adding all those discs together, is going to calculate your LV volume. And your volumetric measurements, you're making at the end of diastole and end systole. You want to measure the long axis in apical 4, apical 2 chamber, and match them up as closely as you can, as closely to the longest measurement that you're able to get. And you want to avoid as much foreshortening as you can by trying to cut through the cavity through the center of the true apex, and not off to the side. And you can avoid this by trying to bring your transducer down towards the mid-axillary line and troubleshooting to find your best image. And it's much, much easier to do it in the echo lab where the beds are much better. You have those cutouts, you have better positioning, and definitely more challenging, especially in our ICU patients where you don't have that cutout bed. Their body position may not be the most optimal. They're hooked up to multiple lines. They have circulatory support devices present, and patient cooperation is going to be a key factor as well. And if you're foreshortened, the apex is going to look much thicker. And then if you go from like an apical 4 to an apical 2 chamber, suddenly your apex starts pointing towards the side instead of pointing up vertically. Your contraction is going to look more vigorous, your LV cavity is going to look smaller, and you're essentially going to overestimate your ejection fraction in that scenario. And you can actually do an internal control in patients who don't have significant mitral regurgitation or aortic regurgitation by comparing stroke volume from your 2D measurements and Doppler measurements. And these values should closely match each other, ideally within 5 milliliter. And then I just wanted to include like a reference table from guidelines, just showing your LV volumes and your ejection fraction based on gender. And then 3D methods can definitely help you identify your LV volumes and ejection fraction because here there's no geometric assumptions, right? And you can avoid foreshortening as well. But the technicality is that it's a little bit harder to acquire. You need good images where you can see the whole left ventricle, and it may require that your patients need to hold their breath for a little bit so that we avoid some stitch artifact. When we talk about myocardial wall stress, stress is proportional to pressure and volume, which is essentially like heart size. Um, and the heart compensates for wall stress by undergoing remodeling. And so it essentially increases its wall thickness and muscle mass in order to normalize the load that it's experiencing and to maintain its pump function as much as it can. So some examples of pressure overload would be hypertension, aortic stenosis, hypertrophic cardiomyopathy, and then some examples of volume overload that would increase your heart size would be, significant aortic regurgitation or mitral regurgitation. So in the instance of pressure overload, like here, the myocytes are going to increase in thickness, and then it's going to develop concentric hypertrophy. And then in response to volume overload, the myocytes are going to lengthen and then develop eccentric hypertrophy. And then we classify this LV remodeling based on the relative wall thickness and the mass index. And this is important because LV hypertrophy and remodeling is a pretty strong predictor of cardiovascular events and is associated with worse outcomes. So ejection fractions probably one of the most widely used echo parameters to evaluate LV systolic function, but there are limitations to it. So when you're evaluating ejection fraction, first of all, it requires good imaging, right? Like if you have a lot of foreshortening or suboptimal images, even with contrast, your measurements are not going to be accurate. And it requires geometric assumptions in an instance of like using Simpson's biplane method. It has a lot of inter-observer variability, especially with visual estimation, right? One reader's ejection fraction estimation is not going to be as good, or I mean, just different than another reader's EF estimation. And ejection fraction is dependent on a lot of things, right? On a lot of, so it's dependent on loading conditions. So if you have a patient with reduced preload and severe mitral regurgitation, it's going to cause their ejection fraction to increase from just the significant regurgitant volume. And in a patient with increased afterload in a setting of severe aortic stenosis, that's going to decrease your ejection fraction. And patients with significant bradycardia, their ejection fraction is going to be overestimated because their stroke volume is going to increase. And inversely, in patients with tachycardia or variable R to R intervals like atrial fibrillation, you're going to have an underestimation of your ejection fraction. And in situations where you have a lot of LV remodeling, like we just previously talked about, ejection fraction can actually be normal, but your systolic function is going to be abnormal. So for example, if you have severe left ventricular hypertrophy, you're probably going to have a small cavity size, and your end diastolic volume and your stroke volume is going to be reduced, but your ejection fraction is probably going to be normal or even increased. So maybe other types of methods to evaluate systolic function, like strain, may be better for these types of patients where they have a preserved ejection fraction, but they have a lot of geometric confounders. So another method to evaluate systolic function is the Tay index of myocardial performance. And this can be done in two ways. The first way is by spectral Doppler. And from what I read, you could either use CW or like a dual pulse wave Doppler to look at the LV outflow and the mitral inflow. And then the second way is by looking at tissue Doppler velocity at the LV annulus, either at the septal annulus or the lateral LV annulus. And with the first method, you can place your cursor in between the region of the LV outflow and mitral inflow so that the machine can try to catch both of them. And then it'll display the spectral Doppler for both LV outflow and mitral inflow, like here. And then you can also do this using pulse Doppler method, where you pulse wave two regions, like the mitral and the aortic flow separately, and then you kind of just combine that data together, like here. And then I just wanted to put an example. This is just from guidelines, and it's just kind of showing their technique of how they're doing the pulse Doppler method. But here in this example, they're looking at the RU function. But technique should be pretty similar for LV as well. Okay, so then, you measure time intervals between the mitral valve closure here and opening here. So interval A, and then you measure the time interval between aortic valve opening here and closure here. So that's interval B, and that's known as ejection time. And then you subtract the time interval from when the mitral valve closes and opens by the time the interval of the aortic valve opening and closing again. So after that subtraction, you're going to be left with a total time of a combined isovolumic contraction time plus the isovolumic relaxation time. And the Tay index is calculated as the isovolumic contraction time plus isovolumic relaxation time divided by your ejection time. So essentially what it all means is that the more reduced your systolic function, the higher the Tay index, right? So it means if you're spending a longer time in the isovolumic phases compared to your ejection phase, your heart's probably sicker, because a sicker heart is going to spend a lot of time generating pressure and then releasing pressure. So something one of our former fellows told me that I kind of have stuck in my mind is like, if you're looking at, isovolumic contraction time, you're thinking about, okay, it's like kind of getting ready for work. And then ejection time is like actually doing work. And then isovolumic relaxation time is like unwinding after work. So if you think about it, if you're spending a lot of time getting ready for work and then relaxing after work in relative comparison to actually doing work, something's wrong, right? And then anything It was harsh.
Less PG version.
Yeah. Yeah. And then the normal Tay index is less than 0.4, and anything greater than that value is abnormal. And then for the second method, Tay index is calculated using tissue Doppler velocity, and this can be done at either the medial or lateral LV annulus. And just looking at the waveforms here, so the isovolumic contraction is your first up and down wave. Right after A wave here corresponds to your QRS on your ECG. Then you have a systolic velocity, and then right after that, you have an up and down wave where you have your isovolumic relaxation. And then that's followed by your E and A wave during diastole. And again, the Tay index is calculated the very same way as before, isovolumic contraction time plus relaxation time divided by ejection fraction. And then I just wanted to put an example here of the tissue Doppler velocity method from guidelines. And again, this is looking at RV function, but it's just an example of how they're doing it. All right, so now we're going to move on to speckle tracking and strain imaging. And this topic is going to be further discussed in a separate lecture in the next few weeks, but we'll briefly go over some important concepts. So echo strain imaging is originally developed as an extension of tissue Doppler velocity imaging. And the idea is that it tracks the movement of these small digital pixels called speckles, which is generated by the interaction between your ultrasound waves and your cardiac tissue. And the percent of shortening or deformation between 2 points of your segment or your object is known as strain. And strain is helpful in estimating global and regional systolic function. It's nice because it's angle independent of your ultrasound beam, but it still requires good imaging. And speckle tracking allows us to look at longitudinal, circumferential, and radial parameters of motion, but the reliability and reproducibility of radial and circumferential strain, it's not quite ready for clinical use. So when we look at deformation or strain, we're predominantly looking at longitudinal strain. And longitudinal strain is the change in your object length divided by your original length. And we can also calculate ejection fraction by volume strain as well. Okay, so in global longitudinal strain, you essentially look at 3 apical views. Each view is divided into 6 segments, and the segments are displayed into a parametric bullseye map. And each segment has a calculated strain. So like for in this example, in your basal anterior segment, your strain is going to be minus 16%, which essentially means the segment shortened by 16%. And then you can average all of the strain from all your segments, and that's going to give you your global longitudinal strain, which in this example is minus 24%. Oh, okay. So global longitudinal strain is it's a more sensitive marker for systolic function compared to ejection fraction. It's good for detection of subclinical LV dysfunction, especially in patients who have cardiomyopathies, patients undergoing chemotherapy treatment, and even in the presence of a lot of cardiac remodeling, like what we talked about, where your ejection fraction is still within the normal range. So it's good for these types of scenarios. And in most progressive myocardial diseases, your longitudinal strain is going to go down early. It's going to decrease early on, but your ejection fraction is going to remain normal. And this is because your circumferential and radial functions tend to augment and compensate in order to maintain stroke volume for as long as it can. And different software from different vendors are going to derive your global longitudinal strain differently. So in general, the consensus is absolute values of global longitudinal strain of greater than 18 is normal, and the more abnormal strain values, the worse the clinical outcomes. And when we think of abnormal values of strain, we often think of, decline in your ventricular function. But there's also other factors too, like preload, afterload, and heart rate can also affect our values. And so that's why it's always a good idea, especially if we have strain imaging, to record your blood pressure and your heart rate. So another method to evaluate systolic function is by using systolic index of contractility. So it's defined as the mean rate of increase in pressure over time during your isovolemic contraction period. So essentially, how quickly does your pressure change within the ventricle during contraction? And it's a pretty good measure of LV contractility, especially in patients where you have mitral regurgitation and a nice central jet. And you record the mitral regurgitation velocity using CW, and you select 2 points. One point is at a velocity of 1 meter per second, and another point is at a velocity of 3 meter per second. And then your systolic index of contractility is calculated by taking the pressure difference between those 2 points, divided by the time it takes to go from that 1 meters per second to 3 meter per second. And then you multiply everything by 1,000. And the sicker the heart, the more reduced systolic function and the longer time it takes to generate pressure. So lower values are going to be associated with reduced systolic function. And again, a good mitral regurgitation signal is mandatory for this method. Eccentric jets don't work very well because, it's going to be hard to align your CW Doppler to get a good signal in a jet. And the method is inappropriate in the presence of acute mitral regurgitation because you're going to have a really high left atrial pressure. And I just, this is just a brief example of how to calculate it. So, you take the pressure difference going from a velocity of 1 to 3 meters per second, and that's always going to be 32 millimeters mercury. So basically the only thing that really changes is the time that takes you to go from one point to another. And then you multiply by 1,000. And in this scenario, they're getting, 452. So that's pretty reduced. Okay, so we're going to transition from talking about global left ventricular systolic function to regional function. And regional wall motion abnormality is mainly the thing that we're looking at. And it may not be seen in patients with coronary artery disease until they have stenosis of greater than 85% at rest or greater than 50% stenosis with stress. And even patients who have normal ejection fraction, like patients can have normal ejection fraction despite having regional wall motion abnormalities. And it's partly because in like an acute setting, non-infarcted myocardium can be hyperfunctioning due to an increase in your catecholamines. So the main point when it comes to this topic is that when you're evaluating regional function, you have to look at 2 things, wall thickening and excursion, even though probably wall thickening is like the thing that you should really be focusing on, because if you have a patient with tethering, for example, like you have infarcted myocardium and it's being pulled by an adjacent normal myocardium, even though it's going to look like the motion and the excursion of that infarcted segment is going to be normal, but the thickening will definitely not be normal. And just one final point here. So you can have regional wall motion abnormality in instances where you don't have coronary artery disease, right? So you're thinking about patients with left bundle branch, RV pressure and volume overload, post-operative septal motion, and then of course, your myocarditis, sarcoidosis, and Takotsubo cardiomyopathy. And we evaluate regional function by dividing the left ventricle into a 17-segment model, which also reflects the coronary perfusion territories. And it's important to understand the coronary territories that pertain to each myocardial segment. And when you're evaluating your myocardial segments, you want to be able to look at it in multiple views. And a wall motion score can be assigned to each segment. So normal myocardium, like a normal segment would be given a score of 1, or normal hyperkinetic would be given a score of 1, hypokinetic a score of 2, akinetic a score of 3, and then dyskinetic or aneurysmal is given a score of 4. And then you calculate wall motion score index by adding all those wall motion scores together and dividing by 17. And a normal score index is going to be 1. And the higher your wall motion score index, the more abnormal the wall motion. Mm-hmm. And just a reminder for us all, contrast agents can be used when you need it, especially it's going to be helpful to delineate global and regional wall motion abnormality. And then just going back on, yeah, so regional strain can be helpful as well to detect regional abnormalities in patients with coronary artery disease or selective cardiomyopathies like amyloid, sarcoid, apical hypertrophic cardiomyopathy. So, just briefly, for example, you're going to see that apical sparing pattern in patients with cardiac amyloid, or, if you have a patient with LAD infarction, for example, you're going to see a reduced strain pattern in the septal segments like here. Okay. So I'm just going to summarize kind of what we talked about, and then we'll go through some fun cases, and that'll be it for today. So in summary, there's a lot of ways to evaluate systolic function using echo. Volumetric measurements with the method of discs and ejection fraction calculations are most commonly used, but you can encounter some issues, especially with foreshortening, interobserver variability, especially with visual estimation also. And giving contrast and using 3D echo can help improve your images and reduce foreshortening, but it's more technically challenging. And measuring stroke volume by Doppler can also provide an internal control to your 2D volumetric measurements too. And then finally, speckle tracking and strain imaging may be better to detect subclinical LV dysfunction for patients with preserved ejection fraction from geometric confounders. So these are my references. All right, on to the practice cases. Do we have any questions before we do? Yes.
What time frame do you recommend?
I think in that type of scenario, and a lot of the attendings can kind of add their, oh, sorry. So Gloria was asking patients who've had, you're saying like infarction, and had a subsequent stent placement, and then were asked to do an echocardiogram to evaluate ejection fraction, is what you're saying, right? I think more in those types of scenarios, you're looking at a couple of things initially, especially for those types of patients who've had an MI, and even with subsequent revascularization, you want to check out what type of ejection fraction you're dealing with to further risk stratify them to see like, okay, what kind of DMT you're thinking about? Do they need, are we thinking about LifeS? Are we thinking about ICD later on in the road? But also to evaluate for any sort of subsequent like mechanical post complication after infarction, right? A lot of, ideally after revascularization, a lot of the times we see that the ejection fraction may be reduced, and hopefully optimally in an instance where the myocardium is a little bit more stunned, and it takes more time for the myocardium to kind of get back to its function. And hopefully, you know, with good GDMT and good management, you can reevaluate 3 months later. If you actually truly have a reduced ejection fraction, you evaluate 3 months later and see if they have improvement in their function, and that the myocardial stunning has improved. And if it hasn't improved despite revascularization, it may be a little bit more poor prognosis. Mhm. I don't think there's an actual time frame. Yeah, just like, you know, by hour by hour. Yeah, I don't think it would actually make that much of a difference if you did it at like 2 hours post stent versus like 4 hours post stent. Yeah. Yeah. Yeah, and make sure we're not missing any sort of other complications out there. Yeah. Mhm. All right, let's move on to our fun cases. So the first couple are going to be pretty easy, and then the couple after that, still easy, but a little bit more of a thinker. Okay, so what's the ejection fraction? What do you guys think? Everyone's very confident. It is C, right? So it's pretty hyperdynamic, the systolic function that we have here. All right, next case. What's the ejection fraction? Okay, so it is B. We're doing good. So, I mean, you know, it's not too bad, right? The systolic function is not too bad, but it doesn't look completely normal. Slightly, very mildly reduced, especially if you're looking at like here, right? Yeah, so 45, 50%. All right, one more. What's the ejection fraction? Okay, wait. We're all good? Okay. It's A. Yeah, it's pretty bad. So we have severely reduced global systolic function. All right, two more cases. So we have a 78-year-old woman. She had hypertension, dyslipidemia, diabetes, chronic kidney disease, comes in with chest pain and troponin elevation. And you have to decide, where's the lesion? Is it in the LAD, the circumflex, the RCA, or I don't know. You guys are confident with your answer? Okay. It's the LAD. So let me go back. Okay, so you have akinesis, right? Look at this segment here compared to like this segment here. Like this one looks like it's thickening really nicely, but this one not so much, right? So here you have akinesis of the mid to apical anteroseptal, mid to apical infroseptal, and apical inferior, as well as the true apex. And so it's consistent with an LAD territory. And so this patient went for a cath. And I don't know about you, but this looks pretty tight here. So they have severe obstructive disease in the mid-LAD, but also in the ostial portion of a very large first diagonal branch too. Okay. And then they underwent successful PCI to the LAD and the first diagonal branch, and it looks much better. Okay, last case. 45-year-old man, he has a history of aortic stenosis, dilated ascending aorta. He had a bioprosthetic aortic valve and an ascending aorta replacement 1 year ago. He comes back and he says, hey, I have chest pain, and he has troponin elevation. Where's the lesion? What does everybody think? Oh, shit. One more time. Okay. I'll give you 10 more seconds. Oh, shoot. All right. So it's the LAD. It's the LAD. So let me go back. Okay. So you have akinesis, right? You look here. So everything looks like it's thickening pretty well until you get to the apical segments, right? And look at that true apex. It's not really doing much when we talk about thickening. The motion, I think everything's kind of pulling it around when it comes to excursion and motion, but thickening, not so good, right? And it's consistent kind of all throughout apical 4, 2-chamber, and 3-chamber. So you have akinesis of the apical anteroseptal, apical inferoseptal, apical inferior, apical anterior, and your true apex. That's an LAD territory, right? Because as you get more distal like that, the artery that feeds a lot of those segments is your LAD. So they went for a cath. And it looks like there's an abrupt stop in blood flow here. And they found an acute thrombotic occlusion of the mid-LAD here. And then they had a successful intervention and was revascularized. And it was suspected that the acute thrombotic occlusion of that mid-LAD was possibly from an embolic process from their prosthetic aortic valve. And they underwent a TEE, and it showed really thickened valve leaflets, mobile echo density at the base of the anatomic non-coronary cusp. And then I'm just going to put color on that. All right, that's it.